Welcome to ATCM Emergency Channel. Today we'll be discussing a case about a CLD patient presenting to ER with altered sensorium and reduced response. A 49-year-old male patient, known case of decompensated CLD with portal hypertension, child C-score MELD 23, was brought to ER with nausea, reduced response and altered sensorium since morning. Patient was drowsy and GCS score was E4, V4, M5. Immediately patient was connected to the monitor and GRBS taken and was 140 mg per deciliter. On primary survey, airway patent, no pooling of secretions, no gurgling, hoarseness of voice. Breathing, patient maintains a saturation of 98% at room air with respiratory rate of 18 per minute and air entry bilaterally equal. There was no added sounds. Circulation, BP was 120/80 mm Hg with a heart rate of 86 per minute. Peripheral pulsations were felt bilaterally equally. Disability, GCS score was 13/15, pupils 3 mm and equally reactive to light. GRBS was 140 mg per deciliter. Exposure, temperature, patient was febrile. On VBG, it showed...
Okay. So usually what will happen is, whenever a patient comes outside the ER, we will get an information from the triaging staff that one patient they are bringing so and so patient. So usually they will have a pass history. So this time you already came to know that this patient is a known case of CLD with child C status. So patient is brought and we have a short history that patient is drowsy. So whenever we are taking a patient in, we need to decide which bed to put that patient in. So usually how will we triage patients? So we have beds here. So some beds are red beds. So what is red bed? Immediate or very urgent care. What about yellow?
Less.
Urgent care. And green? Later care can be given. Okay. So when we get a history or when we see the patient in the triage, we need to move the patient to resuscitation area or whichever bed is required. So that we need to classify based on the color coding system. Okay. So when you get an information like this, how will you plan on triaging the patient?
Green.
This patient can't go into green category because GCS is low. So any walking patient, we can shift to green. If no other airway compromise or nothing is suspected, a walking patient, looking stable patient can be shifted to green area. Then if we are having a lot of patients and if we are seeing a patient who is not breathing, okay, if a patient is not breathing, then we will have to do some airway manual. So this patient you told the airway was patent, but otherwise if the patient is not breathing, we will have to do the basic manual like head tilt, chin lift, and we will see whether the patient is breathing or not. So if it is like a scene of a disaster scene and all, and if after maintaining the airway and after opening the airway, if patient is not breathing, then we will have to declare the patient as dead and we will have to move on to other patient. But in our resuscitation area, we are having we should identify it as a cardiac arrest based on the pulse and all, and we will have to take to red area. Okay, so that is actually patient will be marked as black if it is in a disaster scenario, or else we will have to consider it as cardiac arrest or something, and we will have to move to the red area. So if after opening airway patient is breathing, then some problem is there, that's why patient is not able to breathe, so this patient should be moved to red area. Okay, then what is next? So we are seeing a patient who is breathing, then how will we decide this patient requires red or not? Respiratory rate. If the patient is very tachypneic, then that means there is some problem with breathing. This patient also should go to the red area itself. Then if breathing is also normal, then how will you circulation. So when the patient is coming inside the ER and the triage area itself, we won't be able to take the blood pressure. So in that case, we can check what? Peripheral pulsation. Peripheral pulses or the capillary refill time. What is a normal capillary refill time?
Less than 3.
Less than 3 seconds. So if the patient's CRT is very low, like 4 or 5 and all, then this patient also will require a red bed. So airway we have discussed, breathing we have discussed, and circulation. Okay, so airway compromise suspected, red. Breathing problem, red. Circulation problem, red. Then disability is the sensorium. So if this a patient is coming with altered sensorium and all, then such patients also should go to the red area. And all other patients should be categorized as yellow, like patients who are not able to walk but airway, breathing, circulation, disability is okay, but patient requires other management like an open fracture, such things and all should be going to the yellow area. So this patient should be received into the red area. Okay, so airway wise, airway was patent. So what compromise will you suspect in airway in a case of CLD patient? What all things should you anticipate? There can be any secretions can be there, or hematemesis can be there. So vomitus can be there. Then because of their edema, there can be swelling over the face, these things and all, and tongue fold can also be there. So such things should be anticipated. Okay, and so in the primary survey everything is looking normal except for the GCS, and you have taken a blood sugar which is normal. Okay, then what other so why was VBG asked for this patient?
To know whether there is any metabolic
causes. Okay,
so, it showed a picture of metabolic alkalosis.
Okay, do you have the values?
No.
Okay, so this patient had metabolic alkalosis. What else will we see in the VBG, in our VBG?
Creatine, renal functions, lactate level.
So basically in CLD patient, what we specifically need to look for is GRBS already checked. Then there can be dilutional hyponatremia. Hyponatremia can cause altered sensory. That should be checked. Then what is the most common ABG abnormality seen in a CLD patient? Most common is respiratory alkalosis. Why? Because they are having abdomen distension, these things and all, they will be having an alkalotic breathing. So because of that, the most common ABG abnormality is a respiratory alkalosis. Okay, so if we are seeing a metabolic alkalosis in this patient, we need to find what the cause of that is. So any other thing was there in the ABG? Any electrolyte abnormalities or anything?
There was hypokalemia.
What was the potassium in ABG? 3. Can potassium cause, low potassium cause metabolic alkalosis? It can cause, because
metabolic alkalosis.
Can cause hypokalemia. So either it can be because patient is in metabolic alkalosis, maybe because patient might be taking, patient might have some diarrhea or something. Metabolic alkalosis can be because of different reasons, either some diarrhea or patient might be taking some lacilactone, some kind of medicines that might be the cause of metabolic alkalosis. Because of that, body is in alkalosis. So what the cells will do? Cells will have a tendency to to excrete more potassium into the blood vessels so that the alkalosis will be compensated. So the H plus ions in the cells will go to the circulation. Instead of that, the potassium will enter inside the cells. So potassium and hydrogen ions will get exchanged. So potassium will go intracellularly and H plus will come out. So that might be because of a shift hypokalemia which might have happened in this patient. We are not sure. So that it might be contributing to that. Okay.
ECG normal sinus rhythm, no features of hypokalemia. Ample history, patient known case of decompensated CLD, child score C, MEL 23. Etiology, patient was alcoholic. No drug allergy. Last meal taken in the afternoon. Routine medicines, patient were on Ditor plus.
Okay.
Patient was apparently normal 1 day back. What
is Ditor?
Spironolactone plus torsemide.
So that might be the cause of metabolic alkalosis.
Patient was apparently normal one day back and he was doing all his activities by himself. So he developed nausea and drowsiness since morning. By afternoon, there was worsening of the sensorium and patient was brought to the ER. Enema was given from the ER and he passed stools. No history of fever, cough, vomiting, abdominal pain.
When was the enema given? That day morning or?
No, from the ER.
Okay, that we can mention later on. Okay.
No history of fever, cough, vomiting, abdominal pain, dysuria, hematemesis and melena. On general examination, no pallor, icterus, cyanosis, clubbing, lymphedema and edema. GCS 13/15.
Okay, before moving to examination, we'll ask about the history. So from history itself, we have got some clues regarding the medication. Maybe because the medication induced metabolic alkalosis and hypokalemia might be one cause. So in CLD patients, a patient is coming with altered sensorium. What all things should be in your mind?
It can be due to a upper GI bleed.
What can be? What are the DDs based on the altered sensorium with CLD?
CLD. Patient can go for any electrolyte imbalance.
Okay. Maybe a hyponatremia because potassium abnormality will not cause an altered sensorium. So, hyponatremia can cause, dilutional hyponatremia can cause altered sensorium.
Hypoglycemia can cause.
Hypoglycemia can be there because of the liver problem. Then,
hypovolemia can also cause.
Hypovolemia, hypotension. Hypotension can cause a reduced perfusion to the brain and altered sensorium. Then, hepatic encephalopathy. Then,
SBP can be.
SBP induced decompensation can cause a hepatic encephalopathy and cause. Then, what is the most common? Why are patients developing CLD?
Alcohol.
So, alcohol withdrawal and alcohol intoxication also can cause altered sensorium. They also can come with altered sensorium. Then even though if these patients are taking alcohol, they might have a history of fall. They might not be knowing. So there can be a head injury and IC bleed also. Another one causes, these patients can have coagulopathies. So they might not be evaluating for, already this patient is child C, so they are prone to have some coagulopathies, these things and all. So that itself can cause a spontaneous IC bleed. That also can cause altered sensorium in the patient. And patient who is always taking alcohol, they can go into Wernicke's encephalopathy also because of deficiency of thiamine. Okay, so these should be the DDs initially. Okay.
GCS 13/15.
Then history wise, what all things will you ask?
Whether there is any hematemesis, melena to rule out
GA bleed, which is contributing to the hepatic encephalopathy.
Then whether there is any infection, so we ask about fever, cough, and that. Dysuria to rule out UTI, dysuria, abdominal pain can be asked out. Then about their diet, whether they have taken any excess of animal proteins in the past. About their bowel pattern, whether there is any constipation or not.
Then other infection which you need to suspect? SBP. Okay. Or any recent alcohol intake.
Can be asked. GCS 13/15, moving all limbs but not to the commands. Flaps was not able to be elicited as patient is drowsy. Per abdomen, soft, non-tender. There was mild distension, no guarding or rigidity. Other systems were within the normal limit. On lab investigation, potassium was 3. Ammonia was 126. USG was taken. It just showed the features of CLD with patent portal vein and signs of mild ascites. Chest X-ray was not was taken but within normal limits.
So based on patient's history, what all investigation do you feel is relevant for this patient?
Potassium.
Potassium is anyway we are seeing a metabolic acidosis and hypokalemia in the ABG. So potassium is required. Then ammonia.
Then to rule out whether there is any infections or not, we can send for URE and CBC.
Okay.
Then to see the bowel, whether there is any gaseous distension, we can go for a USG.
Okay. What are you suspecting? Obstruction. Obstruction, ideally you can take an X-ray abdomen and see if there is an obstruction and all. In ultrasound, usually intestinal obstruction cannot be diagnosed. Only dilated bowel loops can only be seen. You can check for any ascitic fluid or anything is there which can cause SBP. Do you think a neuroimaging is required for this patient? If you are suspecting, you should do, because this patient initial presentation was hypokalemia. Okay. Sorry, altered sensorium.
So it is a case of decompensated CLD with hepatic encephalopathy grade 2 to 3 secondary due to hypokalemia.
Okay.
Management, lactulose enema was given.
The problem is with the enema. So you're starting with enema. Actually, the treatment of hepatic encephalopathy is enema, and understand. But the problem is this patient is having a low potassium, and potassium can be lost through the bowel also. So we need to correct that. So correction should be there, and also then only we'll plan on doing this. So management will start with airway, breathing, circulation. So in this patient, airway, we should check for the airway. It is actually patent. Then breathing, circulation, rest of things. Then we have to treat only the disabilities of this patient. Okay, so how will you correct the potassium? So lab potassium, how much was it?
3.
3 was the potassium. So how will you correct?
For every 0.3, we have to give 100 milliequivalents of potassium. So potassium was given as IV.
How will you give potassium IV?
Through the peripheral lines, we can give 20 milliequivalents. So it was given. Or
How will you give 20 milliequivalents?
Through the peripheral line, it was given.
So how much does an ampule of KCl contain? So it comes as an ampule. So one ampule will contain 10 ml. 10 ml is equal to 20 milliequivalents will be there. So if we are having a peripheral line, like peripheral lines, do you know the cannulas and the sizes? So we have different color coding for cannulas. So you have a 20 gauge cannula that is pink in color.
18 is green.
18 is green. Then
16 gray.
16 is gray. Then orange is there. That is 14. 14 orange. So minimum this patient will require a 20 gauge cannula to correct 20 milliequivalents. Okay. What are the other cannula sizes? Small sizes. There's a blue color.
22.
That is 22. Then 24 is there. Yellow color. Okay. Then we have 26 and all, that is purple color is there. Okay. So this patient, what cannula was placed? What color? Do you remember?
20.
20. Pink was placed. Okay. So if we have only peripheral lines, we can give only maximum 20 milliequivalents. How will you give? So we have told that 10 ml contains 20 milliequivalents. Then can you give it directly?
No, dilute.
Dilute
in the 100 ml in this.
We have to dilute based on the patient's what is a potassium is actually an irritant. So if we are giving through the veins, it can cause phlebitis of the veins. So it should be given through NS in 500 ml NS. If the patient is not having a tendency for any fluid overload and all, you can give in 500 ml NS and over 5 to 6 hours. Slowly only you will have to give with a cardiac monitor connected, because we don't know whether it can go to other problems like arrhythmias or anything. Okay.
Orally also given. Orally 15 ml contains 20 milliequivalents. So it was given then.
One important thing which you forgot is that this patient, we have diagnosed it as a metabolic hepatic encephalopathy secondary to hypokalemia. If we have diagnosed that, the major investigation which you send is ECG. Why ECG?
Any hypokalemic changes?
Hypokalemic changes are there. No. If hypokalemic changes are there, then you need to correct potassium very fast. You will have to place a central line and you will have to correct potassium very fast. If hypokalemic changes are not there, then it is fine to give slowly. Okay. So what all hypokalemic changes will you observe in this patient?
flat P wave will be
T wave will be flat initially, then U waves will be there. U wave will be a negative deflection will be there, then
Prominent U wave.
U wave will be there, then
PR interval.
prolongation.
PR prolongation, QRS prolongation will be there, and arrhythmias can be there. So, if there is a hypokalemia induced ECG changes, as it worsens, there can be hypokalemia induced cardiac arrest also. So, in order to prevent that, you will have to put a big cannula like a central line or something, and we'll have to start potassium correction as early as possible. So this patient we had only was ECG
normal sinus rhythm.
normal sinus rhythm. So this patient you can correct slowly. This patient we have a 20 gauge cannula, so 20 milliequivalents was given. How can you suppose you are having an EJV, how will you correct?
40
milliequivalents can be corrected in 500 ml NS can be given. So through peripheral cannula maximum 20 only we can give, through an EJV maximum 40 can be given, and if we have a central line we can give more. Okay. Then syrup was given.
Yes.
15 ml.
15 ml containing 20 milliequivalents was given.
But is patient in a sensorium to take that syrup? No. So we can't give it right now. And since it is CLD patient, we don't know whether there is any varices or anything inside. So it will be difficult to put a Riles tube also. It can injure the varices also. Okay. What are other dietary supplements you can give if the patient is able to tolerate?
Tender coconut.
Tender coconut water. Then banana. Fruits like banana, mango, mushrooms, these things can be given. Okay.
Then ask the patient to avoid any animal protein containing diet. If ascites is increasing, then ask the patient to restrict the fluid salt intake.
Okay. So, what other things which can be done for this patient is, so we know that this patient is having low potassium which has contributed hepatic encephalopathy. So, how can hypokalemia cause metabolic encephalopathy? Hepatic encephalopathy.
Motility.
It can cause hypokalemia induced motility problems can be there, and hepatic encephalopathy can happen. But this patient was passing 3 stools a day. Then why this patient developed hepatic encephalopathy?
Drug-induced hypokalemia.
It is drug-induced hypokalemia, but how can this hypokalemia cause? Because low potassium can increase the ammonia genesis from the kidney. Renal ammonia genesis will increase, and that's why the patient's ammonia went up to 120 even after passing stools. That's why this patient developed hepatic encephalopathy. Okay. So mainly this patient requires potassium correction and also alteration in the medication which patient is taking. This Ditor can be converted into spironolactone or some potassium sparing diuretics, and we'll have to more than the enema, because already patient is passing stool, more than the enema, the potassium also should be corrected in the patient. Okay, suppose this patient was not a CLD patient, how will you evaluate for a hypokalemia? So what are the other causes of hypokalemia which you know? It can be because of a loss of potassium from the body. How can potassium be lost from the body? Drug induced or diarrhea, then vomiting, then sweating can cause, then Riles tube insertion and aspiration also can cause hypokalemia. Okay, then there can be renal losses also. So drug induced is one of that cause, because drug induced renal loss is there. Then other causes? Okay, any diseases that can cause hyperaldosteronism. Like the syndromes like Bartter syndrome, Gitelman, Liddle syndromes and all. That they are salt wasting channelopathies. Then steroids will act like hyperaldosteronism. Steroids can also cause loss of potassium through the kidney. Then one electrolyte, if it is less, potassium also will go down. What is that electrolyte? Magnesium. Why? because magnesium will actually help in reabsorption of potassium from the collecting tubules. So if magnesium is less in the body, potassium will also be lost. So
Before
that
collecting potassium, magnesium will come.
should be checked. So in such patients, if we are suspecting a loss of magnesium also, first we need to check for magnesium, and if magnesium is low, first correct magnesium, then only correct potassium. Otherwise all the potassium if we are given to the patient will be lost through the urine. Okay. Then so we have discussed about the loss of potassium through the bowels, then the kidneys, now we have mentioned. Then where else potassium can be lost? What is shift hypokalemia?
But
Nebulization. So suppose we have a COPD patient, we are giving nebulization round the clock. This patient will go into shift hypokalemia. So in the second day or third day when you check the potassium, it will be low. That is shift hypokalemia. Then glucose and insulin both can reduce the potassium. Then if the patient is in ICU, stay in ICU. If the patient is going to hypothermia, like some patients may not be able to tolerate. If the body is going to hypothermia, that also can reduce the potassium in the body. Okay. Then there is some other cause like spurious hypokalemia. What is spurious hypokalemia? It is based on the sampling of potassium. So it can happen because if the patient's total count is very high and all, and if you are keeping the potassium sample undisturbed for some time, and then we are sending to lab, so there was a delay in checking the potassium. So if the total count was already elevated, in such patients potassium value, if it comes in the lab, it will be low. Or if we are checking the potassium after some time, it might be low. What will happen if you are taking a VBG sample from the vein? No, from the cannula. Hyperkalemia. Why? Lysis of the RBC, multiple prick, these things can contribute to hyperkalemia. So how should a VBG be taken? Venous. So this patient VBG was asked for. So this shouldn't be taken from a cannula. One thing shouldn't be taken from a cannula, it should be taken from a peripheral line. And what the staff will do for placing cannula, they will apply a tourniquet. That tourniquet shouldn't be applied. That tourniquet itself can cause little bit of cell lysis and hyperkalemia. So when we are taking a VBG sample without applying a tourniquet, sample should be taken. Otherwise the sample will go wrong. Okay. Similarly, if the blood is kept undisturbed for some time, the potassium will reduce also. So both things we will have to take care while taking a potassium sample. Immediately after taking VBG, we will have to send the sample immediately for checking, and it should not be a cannula sample also. Okay. So so this patient will have to correct the potassium. Then even after correcting the potassium, so this patient already is passing 2 to 3 stools a day. So that might be enough for the patient. Then we will have to, if the patient is having any constipation or anything, we will have to give enema. Then dietary control to reduce the potassium proteins and also to increase the carbohydrate. Okay. Anything else? So this patient, we have ruled out all the infection, any GA blood, or all the other contributing factors to hepatic encephalopathy. Okay. Then what happened to the patient then?
Patient improved over 24 hours.
Okay. Anything else? Okay, thank you.